autism. So how do those two things go together?
Well, they go together very well because females are always...
So these are only female autistic?
No.
Okay.
We have a mix of females and males, but the autistic females are usually more severely affected. Right. Okay, so they are more representative in that sense of an autistic brain. So the fact that it correlated with the females was actually a good finding, not a bad finding. And the other thing is that, females may not be overrepresentative, and there may be a gender bias, but a lot of the conditions that provide for syndromic autism are biased also in terms of gender, because there's something within the germinal zone that actually protects the periventricular germinal cells, okay, by their hormonal receptors. And estrogen is a protector very early on during development of the periventricular germinal cells. And it happens, for example, in cerebral hemorrhages, okay, where there's a similar gender bias, but it's primarily because of the estrogen effect that they seem to be preserved. In order to have an autism female deficit, the vision needs to be much more severe for it to manifest itself. Please.
Is there any correlation between the mini-columns and the neuronal fibers via DTI?
Yeah, I would say it hasn't been done in terms of autism, but in terms of anthropology, okay, there's a very good correlation, and there's a particular anthropometric index that was developed by anthropologists. And what happens is that the more mini-columns and the smaller they become, okay, the more of a bias you exert in terms of shorter fibers. Okay, so there's an emphasis in having U-type connections, new connections, at the expense of longer connections. And the way that has been explained is almost by a constrictive type of neuropathy, because when you constrain the size of the opening by which those fibers need to pass through, okay, longer fibers are really larger in terms of diameter, and they require more metabolism. So they are more expensive to maintain. So they are the first ones to wither out. Any other question? Oh, please.
Thanks so much for the great presentation. Regarding the findings, lobe-wise, I noticed.
Excuse me.
Regarding those findings on the lobe level, lobe-wise, I noticed that the frontal is the most one that you mentioned.
Yeah.
Like, is this the main lobe that is correlated with autism?
Yeah.
The frontal lobe?
Right, well, you answered your own question, because I have been trying to suggest and indicate some data in regards to the bias in terms of connectivity. And it just so happens that the frontal cortex boasts of the longest connections within the brain. Okay, that's why they also have like the largest cells, because the larger cells have the longer projections. So those are the ones that are affected primarily in autism. Okay.
So with more TMS treatments, does that naturally build those inhibitory connections in an autistic brain? So if you do more and more TMS treatments, eventually can you wean off of those because the neurons have been stimulated enough for growth?
Well, that's what we are hoping for. We are counting on the plasticity of the brain itself to actually make for its corrections, and since we can only stimulate one area of the brain, okay, we were counting for the dorsolateral prefrontal cortex because of its long and numerous connectivity. So we were counting with a cascading effect. So we corrected one area of the brain, but because of its connections to other areas of the brain, then those other areas would become corrected itself.
So how long does that correction last for the treatment?
Well, right now we have longitudinal studies, and we would say about 6 months before they need like a booster session. But the good thing is that we're avoiding neuropharmacological side effects. If you were actually given a patient some neuroleptics, they would gain 40 pounds of weight, maybe a child, they would be somnolent during the day, they wouldn't be able to attend classes, you would be predisposing them to diabetes and all of these very serious side effects. With RTMS, nothing at all. And the other thing is that once you get a booster shot, and maybe, let's say after 6 months, maybe they didn't need to come back for a couple of years. And maybe after you give another booster shot, then maybe they don't need to come back at all. The technique itself, okay, it's available and it's primarily of benefit, but to higher functioning individuals. Those that have like all the structural abnormalities, okay, we cannot correct for structural abnormalities, okay? So lower functional individuals really get no benefit from the technique. It's only proper for higher functioning ones.
Any question? I have one question. What you think for the coming 10 years, what will be the research in the field of autism? What will be the direction? Because many people are interested, especially in my lab, to work on autism. So we need
I think that a lot of the inroads will be in regards to risk factors, because in the end, regardless of the neurodiversity community, we do recognize that autism is a very seriously disabling condition that has a lot of comorbidities with seizures, affective disorders, and so forth. So rather than treatment, we would try to look at prevention. So identification of risk factors, especially trying to expand your portfolios. Don't do genetic studies, but rather try to do genetics in terms of complex or multifactorial conditions. How do they interact with their environment? What makes an autism risk gene to start with? Because they are involved in all sorts of different mechanisms. So rather than studying the function even of the genes, what within their structure, okay, may provide a proclivity towards they becoming a risk factor gene, to have them mutate, for example.
Any question? So before we send Dr. Casanova, we will try to give a small plaque to say thank you for our distinguished speaker, but it is difficult for the student to give something to his advisor. So I am asking the founding chair of the Department of Bioengineering to give to Dr. Casanova.
Wait a second. We'd like to have a